So some major aspects of therapy that are typically associated with good outcomes include a good relationship between therapist and client, which we call therapeutic alliance, meaning that the client and the therapist are allied, are working together to help the client improve their situation. This usually involves trust for the therapist. The client feels that they can trust the therapist. A non-judgmental stance on the part of the therapist. The client isn't being judged for how they're thinking or feeling. And openness on both sides of the relationship. As well, the therapist should be perceived as an expert. There should be an expert role on the part of the therapist. This doesn't mean that the therapist should know everything and should know exactly how to fix the person's problems. It's still a collaborative relationship. It just means that the therapist should have adequate training and skills to be assisting the client in progressing toward their goals. The client should feel like they are building competency and mastery of the skills that they're learning in therapy and the different ways of thinking and behaving. So a client should have self-efficacy. They should feel like they're driving the change process. They should feel that they are able to do this, that they should feel a sense of accomplishment when they change. They shouldn't feel like, oh, well, my therapist did everything. It should be driven by the client, and the therapist should be helping the client to feel that way, and also helping the client to be the one driving the change. And then there are non-specific factors, which the book listed as some kind of like magical factors. I don't know. To me, non-specific factors are things like expectation of improvement, so that the client comes in expecting to get better, and as well, like motivation to change. A client is more likely to improve if they have actual motivation to change, which you'd be surprised. Sometimes people come into the office and they want things to get better, but they don't want to change anything. And so step one becomes kind of creating some motivation to actually change aspects of their life so that things can get better. So there are also client to therapist characteristics that may or may not affect therapy. On the client side, the degree to which a client is distressed seems to have some impact on their likelihood of improving. So your book described like a U-shaped curve where clients with either very little distress or clients with extreme levels of distress are least likely to show improvement. And you can imagine why this might be. If somebody comes into your office, you're a clinician, somebody comes into your office and they really don't have that much that's going on, they don't seem that stressed about what's going on, they're not going to be that motivated to change things, or there won't be that much to change. On the other hand, if somebody comes in completely dysregulated, their life is in shambles, kind of can't, and maybe it's been that way for a long time, it can often be hard to get a foothold in with those clients. It can often be hard to get them enough of a grasp on something that can be changed to really make a difference. Intelligence, most therapies work best at average intelligence or above, or at least above, at least most therapies become more challenging with people who are have lower cognitive abilities. The exception to this would be behavior therapy, which is talked about. There's a chapter on it in your book. I decided not to do a lecture on it for the sake of time in this class, but in behavior therapy, a therapist is helping a person modify their behaviors through changing the environment. It's often something that you do with like children or people for whom more cognitive or interpersonal therapies are not as effective. So there are therapies that are effective with people of lower intelligence levels. And then age, young adults tend to be more likely to change. This is why I like working with young adults. So I work with people in late adolescence and early adulthood, or I did work with them in an early psychosis clinic, and this is also my preferred age at my current clinic, although I work with a lot of people it's great. But one really nice thing about young adults is that they're typically going through a period of time where they are changing anyway, and so they're just easier to convince to change. young kids are sometimes brought there by their parents and aren't really that not as motivated to make behavioral changes. And older adults at times can have lived in their patterns of thinking and behavior for so long that it can be more challenging to get them to act and feel differently. Motivation is also huge. I listed that I talked about that as a non-specific factor, but it's something that we can also study, and we know for certain that people have to want to change in therapy. You really can't force people to change if they don't want something to change. And so a lot of times therapy is kind of forced on people, court mandated or otherwise, and it's very challenging to make headway in those cases. Most of the work of therapy happens outside of the therapist's office. This is a big thing. A lot of people come into a therapist's office and expect that 1 hour or even half hour a week or every 2 weeks is all the work they have to put in. But the truth is that the majority of the work happens outside of that time through homework or changes that person is going to make in their real life, throughout their real life. Openness in a client is also extremely important. So somebody who is open to the therapeutic process, open to trying new things and new ideas. Gender, there's no clear difference based on their research between males and females in terms of outcomes. So therapy in general does not tend to be more effective or efficacious for males or females. There wasn't any information in your book about people with other gender identities, so unfortunately I don't have information about that. In terms of race, socioeconomic status, ethnicity, most therapies were developed by and for white middle class, upper socioeconomic status educated people, and that's a big problem in my opinion, and research indicates this as well. There's need for more diversity in therapists and diversity in the people who do the research on psychotherapy to better understand how racial and ethnic factors may influence what we consider to be gold standards of treatment. As well, socioeconomic status is a huge factor. There are a lot of therapists that I work with that may be from a higher socioeconomic status, and there's often a disconnect in understanding where a client of low socioeconomic status may be coming from, why they might be behaving in that way, because the therapist may not have experienced some of the limitations that are associated with not always having enough resources. Therapist characteristics can also affect client outcomes, and therapists should always be very aware of how their own characteristics may impact the clients that come into their office. So in terms of age, gender, ethnicity, there's no clear evidence that people of a given age, gender, or ethnicity are better therapists. However, there can be an interaction between the therapist and the client in terms of if there's a lot of difference in background between the client and the therapist, it may be more difficult to establish a trusting and understanding relationship. Some limited research does show that ethnicity match doesn't affect outcomes. I'm skeptical of this research. I think there's just not enough research at this point and not in a wide enough variety of people for us to really be able to say that. It's pretty common in clinics, in my clinic and in other clinics that I worked in the past, when a client undergoes their intake assessment, we typically ask if they have any preferences for therapist characteristics. So for example, we ask if they have any preference in terms of the racial background or the gender of the person that they'll be working with. For example, there was a young man that I was working with, or that I was assigned to work with, who decided that it would be better for him if he worked with a male therapist, because he wanted to talk about some issues that he didn't feel comfortable talking about with a woman. And so we found another therapist in the clinic who was a man who was able to work with him. And this is pretty common practice in clinics, and I think kind of speaks to the general observation that a match between the therapist and the client is important, or can be important. If it's important to the client, then it's important and should be respected. Other therapist characteristics that may affect client outcomes include personality. So some people have promoted this idea of the ideal therapist, which has all these perfect characteristics of what a perfect therapist would look like. A few problems with that. One, it's unrealistic, and two, I'm not sure that the ideal therapist looks the same for every type of person. I always joke that I want to make like a dating app, but something like a dating app, like use the algorithms of a dating app, but make so that clients and therapists can find a match. Because I think depending on the client, a client might prefer someone who's like a little bit more directive. Some other people might prefer that they have a less directive therapist. Some people prefer a lot of like warmth and a lot of touchy-feeliness. Some people prefer less of that. So I think that the effectiveness of a given personality type in a therapist really depends on what the client is most responsive to. Certainly there are certain personality characteristics, like if somebody is in general non-judgmental, an open-minded person, someone who is going to make you feel judged is not going to be a good match for kind of any client. As well, empathy, warmth, and genuineness are extremely important therapist characteristics, and this is heavily supported in research. There's a psychologist who was around a while ago. His name was Carl Rogers, and he spoke of this thing called unconditional positive regard, which is the idea that a lot of improvement, or a therapist can serve their client greatly by just deciding that client is a good person and treating them that way. A lot of times clients come into the appointment and they just come into your office and they just don't, there's no one in their life that really truly treats them with total kindness. And I think the therapist can take that role sometimes, and that can that in itself can lead to a lot of client improvement. It used to be thought that this was like that empathy and genuineness and warmth were just like a person either is that way or isn't, but it's more generally accepted now that you can train these things in a therapist. You can train someone to be empathetic and warm and to be more genuine. Therapists should also have good emotional well-being, of course. So if someone is an emotional wreck, they're not going to be able to properly serve their clients. It's very important for therapists to have relatively high self-awareness, recognize their own triggers, their own sensitivities. I knew a therapist once that was going through a divorce and very responsibly said that she wasn't able to see any clients who were going through the divorce at that time because she was just very sensitive to it. She worked with couples, and as well felt that she shouldn't work with individual clients because she knew that she wasn't personally in the right spot to deal with that particular issue. And so therapists should always be working on their own personal issues and also just be realistic about the extent to which those personal issues might affect clients. A lot of therapists undergo their own therapy to kind of work on some of these issues and make sure they're maintaining self-awareness. It's in terms of experience and professional identification, meaning like which mental health profession a therapist is in, like clinical psychology, clinical social worker, psychiatrist. There's no clear evidence based on the research provided in the book that one mental health professional is any better than another one at psychotherapy. In terms of level of experience, so your book kind of alluded to people with more experience not necessarily being better at psychotherapy, and I have to say that really doesn't have much face validity. I really think that might be a misinterpretation of some research. So maybe there's no difference between someone with 10 years versus 20 years of experience, but certainly if somebody has 10 years versus 1 year of experience in psychotherapy, there is a effect. They are more effective if they have more experience. Okay, so the course of clinical intervention, just kind of briefly going over what clinical intervention looks like, what it looks like when somebody comes in for psychotherapy. There's the initial contact, assessment, establishing treatment goals, implementing the treatment, which should take most of the time, and then once the treatment has been implemented, termination, evaluation, and follow-up. So in initial contact, somebody comes into the clinic and there's a description of what the clinic is and the services provided. This is actually really important. Many people come into a clinic and they've been referred, so people might come into my community psychiatry clinic and they don't know really what psychotherapy is. Maybe they were referred by their primary care physician because they were showing signs of depression. They came to the appointment and they're like, I don't really know why I'm here. So it's super important to talk about what psychotherapy is, why they're here, what the procedures are going to be, and also talk about the different roles. So for example, I play the role of psychologist, and I explain what that means, that my specialty is psychotherapy, and I explain to them that they're going to be seeing a psychiatrist whose specialty is medication management and helping them decide if they want to take medication for the psychological problem that they're dealing with. This is really helpful in kind of easing some of the anxiety that people have around sitting in an office and telling a stranger their problems. It's an opportunity to put on the table any reservations they might have about psychotherapy, which are completely warranted, or can be completely warranted. Important to introduce the person to different staff, so important that they understand the front desk staff. This is their role, and it's important, or it can be important, to mention qualifications without being uppity about it, but just, explaining why you might be qualified to be providing these services. Important to discuss fees. Typically the front desk does this. Typically, like, reception discusses fees. Confidentiality is vitally important. So we have a standard sort of spiel that we always give people when they come in for psychotherapy, which is that everything that's said in here is confidential, with the exception, and this is really important because there are exceptions to confidentiality, with the exception of if we deem them to be at risk of harming themselves or others, or if there's information about a child being abused, in which case we have to break confidentiality and report these issues. We also, in the initial contact, are assessing whether the clinic is an appropriate fit for the client. So sometimes people need more care. For example, in my clinic, we can provide up to an hour of therapy once a week. There are people who need more than that, and it would not be appropriate for me to take a client who needs more than an hour once a week if I'm able to refer them to a different clinic that can provide more intensive services. So referring out, if appropriate, is an important aspect of that initial contact. And sometimes initial contact happens over the phone. So sometimes somebody at reception, or if the therapist is making the appointment, will describe this over the phone so that a person can kind of decide if they feel that's acceptable to them, that these terms are acceptable to them. Then there's the assessment. So this is the client comes in and does an intake interview. This might be with the person that they're going to be doing therapy with. It might be with somebody else. This might involve psychological tests, which you're all familiar with now. Typically doesn't, to be honest. Typically it's usually like an interview where a diagnosis is made. So an interview just trying to get a sense of the person's functioning, psychological symptoms, get a sense of the diagnosis so that you can bill. Because if they don't have a diagnosis, you can't bill insurance, and also to get a sense of what treatment you might be offering them. Sometimes the assessment can involve informants, so family members. This is more common in children or people with cognitive impairment that may have caregivers, not really very typical for adults who take care of themselves to have informants in the assessment process. Then the clinician compiles this, analyzes it, integrates it, comes up with a case conceptualization, which is like a little blurb about, this person, Miss X, is suffering from mild depression, which is exacerbated by anxiety and avoidance of going outside, and this may be due in part to a trauma she experienced 2 years ago where she was mugged on the street, something like this, probably a little bit longer than that, to kind of just give your impression of what, not only just a diagnosis, but also impression of what's going on with this person. Again, you can refer out if appropriate after the assessment if you decide that you may not be able to provide the best services for this individual. And assessment is an ongoing process. So assessment can be integrated into every treatment session. The intake assessment is just one snapshot of a person. It's what they're giving you when they first meet you, and they're answering some very specific questions. This might be their first contact with a mental health professional. And so it's important to, throughout the therapy process, keep tabs on if new information is given, to kind of change the case conceptualization, to be open to changing the course of treatment, changing diagnosis, and also doing assessments to track treatment progress. So for example, if a person is suffering from severe depression, you might give them a short depression questionnaire every other time they come in, just to see if depression symptoms are actually decreasing throughout treatment. In the first therapy session, so after the intake session, person goes home, therapist writes the assessment in a week or two, person comes back, and the first treatment session is typically focused on establishing treatment goals. So the therapist and the client negotiate treatment goals. Negotiate is kind of a funny word. More collaborate on treatment goals, although it does sometimes become a negotiation process. And then they kind of enter into a contract where the therapist says, this is what I think the best treatment would be. What do you think about that? And the client says, I don't know, I don't want to focus on depression right now. I really think anxiety is the thing that's really impairing, my life the most. And so the therapist says, okay, and they rewrite the treatment plan. So it's kind of a back and forth. It should include the length of treatment. It should be really clear how long treatment is expected to happen. Often that's depending on, often unfortunately it depends on insurance. So some insurances will only reimburse for 8 to 12 sessions. Sometimes it depends on the diagnosis, how much insurance will reimburse. Sometimes if you're lucky like me and work with only Medicare clients, they will, as long as it's like a serious mental illness diagnosis, they will reimburse for all sessions. So you can engage the client in treatment as long as they're improving and as long as they're willing to keep coming, which is really nice. You also want to establish how frequently a person wants to come in. It's typically best for a person to come in at least weekly. Maybe for some really minor issues, it's better to come in every other week, but for most people, if they're able to come in weekly at the beginning, it's good to get some momentum. The sessions can be more infrequent as time goes on, and then being really upfront about cost, format, and making sure there's a clear sense of what the client expects from therapy. In establishing treatment goals, the therapist has to make sure that the goals are reasonable, because we want to meet the goals. So if a person says, I want to get a job that will pay me $100,000 by next year, and they're currently working a job that pays $29,000 a year, with no skills that would necessarily get them a better job, it's better to say, like, well, why don't we cut that down into smaller goals, and maybe you can look for a job that pays more. It's important for goals to be manageable and measurable. It sometimes can be a good time during the establishment of treatment goals to explore potential barriers. So if a person wants to find a higher paying job, you might say, well, what's preventing you right now from doing that? Because those can be good treatment targets if a person has a sense of what's getting in the way of it. Importantly, goals and contracts modify over time, and in my opinion, actually, the most important part of that first session and of creating treatment plans is to instill hope in the person. So a lot of people come to their first psychotherapy session in a lot of distress and feeling like they can't manage things themselves. Not everybody, but some people do. And I think one of the most valuable things you can give people in that first session and during the planning process is a sense that things can get better and that somebody's willing to help them make things better. One of my clinical supervisors always says the goal of the first session is getting them to come back to the second session, because the median, or the most common number of sessions that a person, so not the mean, but the most common number of sessions that a person attends is 1. It's very common for someone to show up to 1 session and never come back. So it's of vital importance to kind of give that person something to come back for. And then in the second session on, you implement treatment. So the therapist decides with the client on the specific form of treatment that you might do. If you're a CBT therapist or someone who's a little bit more CBT oriented like me, you might do, so if somebody comes in with depression, I always go straight to behavioral activation, which we'll talk about in the CBT chapter, but almost invariably I'll go to behavioral activation, and so we just get started on behavioral activation. Always describe the rationale of the treatment to the client in terms that they can understand, and describe what's involved in treatment. So describing kind of the long-term and the short-term challenges, and potential long-term benefits, and getting feedback on the part of the client to say, do you think that's something that might work for you? Which I think is something that we're not all therapists do as often as they should, is making sure that there's buy-in for the treatment. It's important that a client believes that a treatment's going to work, and important to check with the client that if they think that treatment is going to work for their life. So I mentioned before that a lot of these treatments that we use, these gold standard treatments, were developed by white people in coastal regions of the U.S., of the mainland U.S., who came from an affluent or higher SES background and are highly educated. And it's important not to assume that my predominantly Black or African American clients who didn't make it past 8th grade and have a very, very different life than me and the people who developed these therapies. It's important to acknowledge and respect that these therapeutic techniques may not always be the best fit for them. So it's really important to get buy-in and get feedback from the client. And then if everything works well, if there's, you go through the course of therapy, 8 to 12 weeks or longer, therapists might begin to discuss termination as the client improves and as they're able to handle problems more independently. The point of therapy is to discontinue therapy. The point of therapy is to make a client, or to get a client to a point that they feel like they can handle their life and their problems on their own. And deciding when the termination process should happen is absolutely something that needs to be very collaborative with the client. Important to assess clients' attitudes about termination, important that they don't feel that they're being kicked out or discontinued. Really important to kind of underscore that termination happens when somebody gets to a point that they may not need the therapist anymore. Sometimes, as I mentioned before, you might gradually reduce the frequency of sessions, so going from once a week to about once a month. It's also possible to do what we call like booster sessions, so scheduling a treatment session or a check-in a couple months after their last session to review progress, kind of see how things have been going, if they've been using some of these skills, if any new issues have emerged, or new problems that need to be addressed, and maybe review some of those skills. So maybe they've been, they kind of just have been not using some of those new skills or techniques in the past 3 months, and it's a good time to review. One helpful way to try to think about as a therapist what type of therapy might be the best fit for a client when they come into the clinic is the stages of change model. So different people come in with different awarenesses and levels of motivation regarding the issues that they're facing in their life, and the types of interventions and frequency of intervention should be adapted to kind of meeting the person where they're at, meaning you can't force people along. You gotta kind of work with what they're coming in with. So the pre-contemplation stage, somebody comes in, they have no intention to alter behavior, but there's outside pressure to change. So for example, this might be a woman who comes into the clinic and she says that she's there because her husband forced her to, and he says she drinks too much. So possible substance use issues, but she doesn't believe that she has issues and doesn't want to change her behavior. Somebody else is making her come in and saying she needs to change her behavior. In the contemplation stage, a person's aware of the problem but not committed to changing. So in this stage, maybe you've been working with this woman for a few weeks, and in a roundabout way, she's kind of come around to saying, okay, maybe I drink a little bit too much, but this is how I deal with stress and I don't want to change it. In the preparation stage, the client has the intention to make a change. So maybe our woman has said, you know, I drink to deal with stress, but I can tell like it's affecting my relationship, and I feel terrible in the mornings, and I feel it's starting to feel out of control. So I want to change. I want to do something differently. In the action stage, the client is actively changing the problematic behaviors. So maybe our woman is cutting back a bit on alcohol. In the maintenance stage, this means that they are consistently acting in a way that is more adaptive. And so in this stage, as a therapist and working with the client, we're trying to prevent relapses and increase the gains. So maybe she's not drinking, or she's drinking less. She's only drinking a couple glasses a week or something like that, a couple glasses of wine a week. And we're working with her to maintain those gains, those improvements. At the termination stage, the necessary changes have been made, they're stable, relapse is not much of a threat, and they can discontinue treatment. So some models have, within the stages of change, also include relapse as one of the stages of change, relapse being like the emergence of the initial issue. So I used the example of substance use because the stages of change model is really common in substance use treatment, but this can be for anything. It can be for depression, it can be for anxiety, anything where people might not be fully aware or fully endorse that the issue is causing problems in their life, and can move through these kind of different stages of how they conceptualize that problem, and if they're willing to deal with it and do things a bit differently. I really like the models of stages of change that do include relapse, because I feel like that validates relapse as a normal part of healing. Just because somebody relapses maybe in substance use, maybe goes on a binge or drinks too much one night, or just because a depressed person shuts themselves in their house all weekend and isn't engaging in behavioral activation, doesn't mean that all the gains have been lost. It means there was a relapse. It means there was a small step backward, and it's just an opportunity to regroup and keep moving forward. Some criticisms of the stages of change model is that the stages are not discrete, and this is absolutely true in real life. A person can be experiencing more than one at a time. They might be flipping back and forth between, like, do I want to change, do I not want to change? The stages are also not necessarily sequential, so people can skip stages or go back stages. Behavior change strategies have been shown to be effective with ambivalent clients, so using this model can be helpful with clients who are ambivalent about making changes in their lives. They may increase motivation, although research does fail to show a strong link between the stages of change model and treatment approach. in general. But I do think it's a useful model, and a lot of clinicians use it as just a way to conceptualize how best to approach a client who might be showing ambivalence toward treatment. So there's a section in your book about research in this chapter, and I don't want you to worry about that because we covered a lot of that material last week, and we don't need to go back over it. So feel free to skip that part. And then I want to quickly talk about recent trends in psychotherapy, recent being like the past 10 to 15 years. So there's been an increased focus in general on psychotherapy research, which is great. We are learning more about the therapeutic process and which therapies might work for which different types of people. Better at identifying interventions that work better for specific problems. So rather than just saying like CBT works for people with depression, saying people who tend to withdraw from society and experience depressive symptoms or sadness from this, this type of intervention is better, might be better, because depression can mean a lot of different things, can look differently in a lot of different people, and it is better if we can pair up interventions with more specific behaviors and issues. Research that is supported, there's a big gap between what the body of research says is the best therapy and what people are actually doing in clinics. So there is this kind of like slow process of adopting evidence-based treatments, but this has been a little more of a focus in the past 15 to 20 years. There's also an increase in managed care, meaning like insurance companies and the systems that support psychotherapy services are more likely to reimburse and to kind of require the clinicians to give treatment that's supported by science, and also treatments that are effective and efficient. Manualized treatment is more and more popular. I touched on this briefly earlier, but manualized treatment is literally like a treatment manual that you open and you go through. Like Module A, we do, a thought record. Module B, we analyze that thought record at the next meeting. It was originally developed by researchers, manualized treatment was originally developed by researchers to have standardized research protocol, but these manualized treatments have moved more into the clinic, and there is some debate whether treatment manuals are appropriate in clinical practice. Some say that it's better than clinical judgment, that you should go based on what research indicates is best for somebody that walks into your clinic with anxiety, rather than just saying like, I think based on this person, this treatment might be best. Others say that it undermines clinical judgment, that there's something as clinicians, that clinicians are better at saying what treatment might be best for a person as opposed to just adhering to what research says is best. Manualized treatment can encourage innovation. It does require clinical skills and a therapeutic alliance. So in a manualized treatment, it's not just like a clinician is reading from a book. They are using the book as guidance for things that can happen during the therapeutic session. Manualized treatment, most people agree, should be flexible and allow for mobility on the part of the therapist. Manualized treatment is easier to teach, for certain, easier to supervise and monitor. Clients actually, some clients seem to like manualized treatments. Some clients, and this is anecdotal, but some clients really don't respond to you pulling out a book when they're pouring out their heart to you. So I think depending on the client, depending on the issue, some clients find that it's helps in staying focused in their treatment, and it's consistent with managed care as well.